Okay, so I'm going to go through just a little bit of an overview of some of the concepts that we're going to be covering this week. Immunologic and infectious conditions is one of the things we will be covering that is a very common issue in the pediatric population. Allergic reactions or anaphylaxis, as you can see from your pictures, swelling. They get the angioedema where they get the swollen lips. They sometimes get the swollen eyes, and we are concerned about their airway being cut off. Some kids have allergies to bee stings. Some kids have allergies to nuts. Those kind of kids need to have the EpiPen, as you can see at the bottom of your screen there. They need to have that with them at all times because if they are exposed to any of these allergens, they have a very serious reaction that can eventually lead to cutting off their airway and they become hypoxic very quickly. This can be a deadly problem. Okay, so types of infections. Obviously, there's a viral infection. A good example of that would be the flu or RSV, respiratory syncytial virus. Very common in children under a year of age. 95% of children will have RSV by the time they're 5 years old. To an adult, it's basically just a cold. But older adults can have more serious or significant issues with RSV. A fungal infection could be something like thrush, candida, and then, of course, there's bacterial infection. So a cellulitis or possibly a type of pneumonia could be a bacterial infection. So some signs and symptoms, early infectious condition, unique signs and symptoms. So sometimes they have a fever. Obviously, if it's bacterial, they're going to have a higher fever than if it's viral. Viral tends to be low grade. They may feel kind of achy. They may not have a lot of energy. If you're talking about an infant, they're more irritable, they cry more. If you're talking about a toddler or a preschooler, again, they can be irritable. A lot of times these kids lose their appetites. They can have itching if they have a rash that goes along with this infection. So obviously we want to provide good skin care. We want to make sure that their nutrition is good. We want to educate the families on good hand washing. We want to be very good with our assessment. It's symptomatic treatment, so we want to make sure that we're medicating them for a fever, that we are giving them medications if we can for coughs or for stuffy noses, or if they have itching, we want to make sure that we're giving them some sort of an antihistamine for that. Okay, chickenpox, very common. The varicella zoster virus. This is a form of herpes virus. So the rash first appears on the face or the trunk, macular red base, progresses to vesicles. They are contagious until those spots crust up, until they dry out. This little guy down here, he looks very happy, but usually kids are pretty irritable with this type of problem. They get very itchy. Sometimes they run fevers. Kids can actually progress to pneumonia if this problem is not taken care of pretty quickly. They have a vaccine now available that the kiddos can get. I believe they get it at 12 months of age. So like with most viruses, the incubation period anywhere between 10 and 21 days. They're contagious 1 to 2 days before eruption. So before they actually see the spots is when they're most contagious, but they are contagious up until the spots dry up. In the old days, they used to have what they called chickenpox parties because everybody wanted their kids to have the chickenpox so that they could get it done with. But now that they have the vaccine, I don't think that you hear or see that very often anymore. Rubella, that is the German measles. I actually had this myself when I was a young kid. As you can see from the picture up there, very dense, red, raised areas, pretty much covers the entire body. Very contagious 1 week after the rash presents itself. Airborne in contact isolation. Again, the incubation period, very similar to the chickenpox, 14 to 21 days. Severe fetal complications. We talked about that. If mom has the rubella infection, the baby can have some really significant issues. Mental retardation, deafness, cardiac problems, or the baby could actually be stillbirthed. They don't want to vaccinate while pregnant. They should wait for at least 3 months before they actually, if they get the vaccination, they should wait for 3 months before they actually become pregnant. Rubiola or measles, they get a high fever, they have a cough, they can have conjunctivitis. They have a rash 3 to 4 days, starts on the forehead, spreads to the ears and then the face, the trunk, extremities. They pretty much get it all over. It doesn't look quite as bad as the chickenpox rash, but they can get much sicker from the measles and actually die from it. We had quite an outbreak of this a few years back because children were not being vaccinated against measles and babies were actually dying from it. Again, it's airborne contact. Should start 2 days before rash and until 5 days after rash for a total of 14 days. So it's a communicable disease. It spreads very quickly. As you can see from the picture here, the family that anti-vaxxes together infects the community together. So this is a real serious issue that we have right now going on where parents are not wanting to vaccinate their children. So part of our role as the nurse is to find out really why don't they want the vaccines to be given? What is their reason behind? And then when they tell us, we need to be educating them on, well, this is why we give the vaccines and this is what we're trying to prevent so that they can make a more informed decision. Because what they see on the internet, what they see on television, that's not always truth. That's not always 100% truth. So we need to be providing them better education so that they can make a more informed decision. As you can see down here at the bottom of the screen, it's a reportable disease. It's considered communicable. It's widespread. It can spread very quickly. So this does have to be reported to your local health department. Okay, so herpes, simplex type 1. Cold sores, they get them out in the mouth and the lip area, sometimes around the nose where you see this little guy down here at the bottom. Stress can bring them out. Sunlight causes them to come out. Standard treatment, Zovirax is one treatment that we do give for the herpes. If a baby has it or if mom has it and the infant is born with it, that can sometimes be a little bit more serious. Those babies tend to be a little more sick. They tend to run very high fevers. They can have seizures. Sometimes these kiddos can die from this. So this is actually a pretty serious deal. So it's very important that we know mom's herpes status at the time when she's pregnant so that we can kind of try to prophylactically treat this type of problem. Zoster or the shingles, that's the secondary virus. Doesn't tend to happen in children. It's more so to the adult population. But there are no absolutes in this business, so it can happen. It's basically a re-emergence of the chickenpox virus. They can have neuralgias with the shingles. It can cause nerve pain. And they, again, they are not considered not communicable until the crusts have dried up. Okay, infectious mononucleosis, or better known as mono, this used to be called the kissing disease when I was growing up. Transmission, so it's most common in the 15 to 24-year-old range, contracted through saliva, mucus, and tears. There you go, kissing disease. Epstein-Barr virus, the EBV. So that is the virus that causes this problem. They tend to be very sleepy. They don't have any energy at all, swollen lymph glands, headache, chills. They have liver involvement in some cases, very, very fatigued, not a lot of energy, and it actually takes them quite a while to get over this. They can have temps as high as 104. They get a sore throat. Pain, mid-epigastric or left upper quadrant with spleen enlargement, loss of appetite, body aches. So here's the treatment. Rest, throat soothing measures, so throat drops, low energy impact activity, so try to conserve their energy, cluster care, things like that. Diagnostics, there is a monospot test they can do. They can check their liver enzymes. They can do a cytomegalovirus check. It can mimic the mono symptoms, so sometimes they might mistake one for the other. Okay, so thrush. This is very common in the pediatric population. They get the white patches or plaques along their tongue. They can get it in the back of their throat along with their tonsils. So treatment for this is nystatin. We do the liquid. They swish and swallow if they're an older kid, or swish and spit. For babies, we would take a Q-tip and we would just kind of put it around in the buccal area, along the cheeks, the tongue, and just kind of let it go at that. We wouldn't want them to take it in orally. We just want to put it on the surface so that it will be absorbed that way. Okay, so cardiac conditions, this is a fairly rare problem in the pediatric population. Generally, pediatrics tends to be respiratory before it's cardiac. If they do have a cardiac issue, generally this is going to be a congenital problem, something that they are born with. As far as endocarditis, this is an infection of the inner lining of the heart. So I would say that this is going to be an older kid. As you can see down there, some of the reasons why they get it, it's a bacterial infection. So it can be caused from tattooing. It can be caused from body piercings, contaminated needles. So if it's happening in a younger kid and we're talking about contaminated needles, maybe this is a diabetic kid who isn't very clean about giving themselves their insulin. But generally, this type of infection is not going to happen in a younger kid. It's going to happen in an older kid. An infection, if they have an immunologic issue where they have a depressed immune system, possibly this could happen, but this is not a very common issue for pediatrics. But I mention it because it can happen. It just doesn't happen very often. So a kiddo that has endocarditis, the treatment is going to be very similar to that of an adult. They're going to be have to be on long-term antibiotics. So this kid's going to have a central line, and they're going to be have to be on antibiotics until the infection has resolved. Okay, so congenital heart defects, the most common one is the ventral septal defect. You can have that with tetralogy of Fallot. There's actually 4 different problems. It's a cyanotic condition. It's a right to left shunt. So the unoxygenated blood is mixing with the oxygenated blood. These kiddos go into the tripod position very uh, commonly because they are hypoxic. So they try to conserve their energy. They're trying to conserve their oxygen. So you will see these kids get into the um, tripod position very commonly. The transposition of great vessels, this is a pretty rare problem. I have never seen it. It can either be cyanotic or acyanotic. Basically, the aorta is not attached where it should be. So you can have a mixing of blood sometimes, but it's not as common as other types of cardiac problems. Coarctation of the aorta, it's obstructive. So, the flow gets cut down, so it can cause low cardiac output, and sometimes it can cause shock from hypovolemia. The patent ductus arteriosus, if you remember back when we were talking about the newborn, they have those 4 ducts in the heart, and they should close, or the 3 ducts, I'm sorry, they should close when the baby takes their first breath. Well, a patent ductus arteriosus is a duct that does not close. So this does require surgical revision to get it to close. Okay, so this slide here, congenital defects, acyanotic, left to right shunt, so the oxygenated blood is getting mixed with the unoxygenated blood, increase in pulmonary blood flow. Remember, it's going to the lungs. So the atrial septal defect, the ventral septal defect, and the patent ductus arteriosus, those are all acyanotic, excuse me. Tetralogy of Fallot then is the cyanotic, so decrease in the pulmonary blood flow. It's the unoxygenated blood mixing with the oxygenated blood, so it's going the opposite way. And these kiddos, they get pretty cyanotic. They can actually have a little bit of a blue tint around their mouth or maybe around their eyes. They get tired very easily. These kiddos do require surgery to correct this problem. The ventricular septal defect, this is the most common congenital heart defect in the pediatric population. You can see there on the picture, there's a hole between the right ventricle and the left ventricle. So the blood is being mixed. The acyanotic and the cyanotic are mixing together. So it's basically a shunting problem, and that's where the murmurs come from. That's the sound that you can hear, is that whooshing sound, because the blood is going where it shouldn't be going. Okay, so sometimes, they can live a really long, happy life without any type of intervention at all, and it doesn't really cause too much trouble. But in some cases, these kiddos can end up with a right ventricular overload because of that left to right shunting. It's going from the left side to the right side. So that can kind of overwork that right ventricle. Generally, they need to be repaired surgically, but they do have a transcatheter closer device that's coming along. I haven't really ever seen this in use in practice, but it can happen. So if the VSD is very large, they can have shortness of breath, feeding difficulties, poor growth, fatigability. They get tired really easily. They can have a lot of lung infections. They have a very harsh murmur with a thrill. So these guys, you could generally hear their murmurs. This is part of the tetralogy of Fallot. This is one of the defects that they will have. Transposition of the great arteries. So this happens in utero. This happens while the fetus is growing. They have a septation, and the aorta arises from the right side of the heart, and the pulmonary artery arises from the left. So basically, these vessels are not connected where they should be. This is a cyanotic condition. These kiddos can have shortness of breath. They can have difficulty feeding. They may have clubbing or blunting of their fingers and their toes because of their continual hypoxia. And a murmur is not always present with this problem. This type of congenital defect has to be surgically fixed. Okay, so the tetralogy of Fallot, there's 4 conditions: the ventral septal defect, overriding aorta, hypertrophic right ventricle, and pulmonary stenosis or atresia. This is a cyanotic condition. As I said earlier, these kiddos very commonly get into your tripod position when they get fatigued or when they're having difficulty breathing, because these kiddos will get shortness of breath. Okay, so some cardiac infectious diseases. So Kawasaki's, this is can be common. I took care of a lot of kids with Kawasaki's. They end up with really high temperatures. They get a strawberry tongue, as you can see from the picture in the middle. They get a patchy rash. Their lymph nodes can be swollen. They get conjunctivitis, and they get joint pain. We give these kiddos IVIG, so they can have really high temps, like 103, 104. So these kiddos are usually pretty sick. It's going to sound a little bit controversial, but they do give high dose aspirin for these kiddos for its anti-inflammatory effects. We do tell parents not to give their kids aspirin if they've had a viral infection because of the risk of Reye's syndrome, but with this particular condition, they will give aspirin. Okay, so cardiac catheterization, very common. If they do have a cardiac issue, this is one of the invasive tests that they will do. The care for the kiddo is not really going to be any different than it would be for an adult. We're doing frequent vitals. We're checking the insertion sites. We're making sure that there isn't any significant bleeding or any problems as far as any arrhythmias or anything like that that may have come from the procedure. Okay, so endocrine and metabolic conditions, again, not real common in the pediatric population, but I'll run through a few of these just so that you have an idea. Hypopituitary, so growth hormone deficiency. These kiddos have a short stature. They're less than the 5th percentile. It usually shows within the first couple of years of life that we identify it. They have a delayed closure of their anterior fontanelle, delayed dental eruption. They're not as muscular as we would expect them to be for their age, delayed puberty, and sometimes have hypoglycemia. This problem, the cause of this disease is unknown, but nursing care, so we give them human recombinant growth hormone. We have to treat them age appropriate, even though they're short. I mean, they're developmentally where they need to be, and educating the parents on the condition and the treatments that we will be doing. Okay, so giantism. This occurs in childhood. This happens before the closure of the growth plates. It's caused by large amounts of growth hormone resulting in excessive growth of the long bones in a child. So basically they get to be really tall. It affects 3 to 6 out of every million. So it's a fairly rare problem. It's uncontrolled hypersecretion of growth hormone by the pituitary. In most cases, the cause of this excessive production is a non-cancerous tumor on the pituitary. Kiddos with this problem can be about twice the size as we would expect them to be for their age. As you can see by that picture, that guy is really tall. And it's like I said, it's rare, but it's out there. Obviously, we're going to want to provide support for these kiddos. We don't, when we're children, we don't want to be different from other children, but obviously somebody who's twice the size as we would expect them to be is going to be different. So we need to provide a lot of support to the kid, and we also need to provide a lot of support to the family. Medication is the treatment of choice if surgery can't be performed. Somatostatin analogs or dopamine agonists are effective to reduce the release of the growth hormone. If they go with the surgical option, they're going to try to remove the tumor if a tumor is one that's causing the problem. Radiation is not recommended in children because of the complications and side effects to other bodily functions, but they can do it. Okay, so for the diabetes type 1, juvenile onset, so these kiddos, it's more common than you might think. I took care of a lot of kids with this problem during my practice. The 3Ps, polyuria, polydipsia, polyphagia, they usually tend to be about 10 pounds of weight loss before they come in to get checked. Their glucoses are in the hundreds, maybe 5, 6, 700 by the time they come in to get checked. Nausea, vomiting, abdominal pain, very fatigued. Obviously, they're going to be more susceptible to infection. They tend to be dehydrated when they come in and very irritable. These kiddos have to be taught how to do insulin injections. The youngest kiddo that I ever had to take care of in my practice was 18 months, and they were a type 1. Anybody who lives in the household with this child is going to have to learn how to check their blood sugars and how to do insulin or to give any type of glucose treatment if their sugar goes low. So that includes siblings. As long as the siblings are old enough to understand the teaching, they also need to be taught. They need to be taught the signs and symptoms of hypoglycemia. It's always worse to be low than high. The symptoms are usually worse, and the complications are usually worse from a low sugar as opposed to a high sugar. But all the family members need to be taught what those signs and symptoms are and how to identify them and what they need to do if this problem occurs. Now here's a little better picture of the 3Ps, the polyuria, which is the urination, polydipsia, which is thirst, and polyphagia, which is hunger. Even though they're eating and drinking and peeing, they're still losing weight. They can tend to be fatigued. They have, let's see, a familial tendency. So this is a genetic issue or hereditary, so it can occur through families. Peak incidence from 10 to 15 years. So the kiddo that I took care of was a very rare case. It doesn't usually show itself that early. But can you imagine being 10 to 15 years old and finding out you have diabetes? It's not a very fun disease to have, especially at that age. Okay, for DKA, a lot of times this is what they present with when they're first diagnosed. They don't realize that they're diabetics until this problem occurs. And this goes for adults as well. So their sugars are pretty high. They have ketones in their urine. They have the fruity smelling breath. They can have altered mental status, the Kussmaul breathing. That's usually when it's pretty advanced. Sometimes it comes on from an infection that they may have had that triggers it. They have acidosis, obviously, so they have a low pH. They can have issues with weakness. Sometimes they can have a fever. Obviously, if it presents on the tail end of an infection, they may have a fever. These kiddos can tend to be pretty sick. They're probably going to be in the ICU because they're going to have to be on an insulin drip. I've taken care of several of these kids. Now, we used to do the insulin drips on my unit, but now that is relegated strictly to ICU. They don't do them on the regular pediatric floor anymore. Okay, so as you can see from your pictures here, the diabetic ketoacidosis onset 4 to 10 hours. Sometimes it can be a slow onset, but it's a little faster in kids than it is with adults. Sometimes it can take up to 2 or 3 days before it shows itself with adults. So the blood sugar is above 240. Initially, they're going to be hyperkalemic, but as it progresses and once they get to getting some fluids on board and getting those blood sugars normalized, their calcium or their potassium is going to drop. So in some cases, they may need potassium supplements. That also helps the cells to accept the glucose. Hydration, insulin, electrolyte replacement. So these kiddos are going to be on an actual insulin drip. These are pretty complex drips that they put them on. The sugars have to be checked very frequently and adjustments have to be made very frequently. At the minimum, every hour. So if you can imagine what that might be like to take care of a kid like that has to get their finger poked every hour or even more frequently sometimes, it's really not a lot of fun. Okay, so hyperbilirubinemia we talked about when we were going through the newborn, but basically it's jaundice. Phototherapy is the treatment of choice for jaundice. You can also set the baby in a window for a little while and let them get some natural sunlight that way, or you can tell them to take their baby for walks as long as they don't leave them out in the sun for too long. So basically, we want to feed them frequently, not more than 3 hours. And you want to make sure that they're pooping a lot because that's how the bilirubin is shed, is through the stool. So that's why we want to feed them so much. We want to make sure that they don't get dehydrated with this issue, especially if they're getting phototherapy as the treatment. Kernicterus is the problem that we are concerned about mostly with bilirubin. They have CNS, they're very lethargic, or maybe even in some cases they can become comatose. It can cause real serious problems, and if it gets to that stage, these babies can actually die from it. In some cases, they may have to do an exchange or a plasmapheresis where they actually take the blood out and put different blood in. They would have to go to a tertiary center for that. I don't know of any, I don't think either of the hospitals in this area do it, but I know for sure that they do it in Lutheran General. Okay, this last section is the neuro or sensory conditions. So I'm just going to run through this real quick, just going to pick out some of them to let you know about. I'm basically going over the most common issues that if you were to be in the pediatric population that you would see. The other conditions, obviously, you're going to want to review those and read about them, but I'm not going to put them on this recording. Increased intracranial pressure is not something that's real common with children, but you think about if they have an injury, if they have a traumatic brain injury, that can cause swelling to the brain. Remember, the skull is immovable, and that causes pressure against the brain, and it can cause brain herniation, which then could lead to death. These kiddos can become comatose if it gets severe enough, but the change in the level of consciousness is generally the first symptom that these types of patients will show you. So for the infant, they have a bulging fontanelle. So somebody that has a little baby that has meningitis and they have a bulging fontanelle, I would be concerned about increased intracranial pressure. These kiddos can end up having significant issues. Again, children, decreased level of consciousness, vomiting, changes in their vital signs, decreased sensory or motor function if it gets serious enough. Seizures are a little more common with your pediatric population. The most common type of seizure for pediatric population is going to be your febrile seizures. So if their temperature gets up high enough, they may end up with having a seizure. The treatment and what we do is basically going to be the same. We monitor the seizure, we watch, we make sure that we're timing it to see when it starts and when it stops. We're wanting to provide safety. If they're wearing clothing, we're going to want to make sure that we loosen it so that they don't have anything constrictive. We're not going to want to hold them down. Obviously, we don't put anything in their mouth. And if we have to, obviously, we're going to be putting them on the left lateral so that we don't have them aspirating. Meningitis, another common problem with the pediatric population. They get the stiff neck or nuchal rigidity. Sometimes they can have a pretty high fever. They can have seizures from this. They can have alterations in their level of consciousness. So this is definitely something that we're going to be watching for. If you got a little baby coming in with a fever, a lot of times they're going to do a lumbar puncture on these kiddos to rule out meningitis because it's such a common problem. Okay, so the nurse has to help if they plan to do a lumbar puncture. We get them into the fetal position. We have the knees to chest. We have their head down. So that the back is exposed, or if it's a little tiny baby, like a little neonate or a very small infant, they can actually do it from a sitting position like you see in that picture right there. I've helped lots of docs do it from that way. Not all of them do it that way, but your neonatologist generally will. The most important thing is that the baby doesn't move when they're going into that spinal space. You want to make sure that they don't move. A traumatic tap is a tap that when the fluid's coming out, it's bloody tinged. So that's not actually a good tap. What they're generally looking for with the spinal tap, they're checking cell count, they're looking for gram stain, and of course a culture. So shaken baby, they can have seizure activity, they can actually become apneic, they can have coma, hemorrhages, they can have bursted blood vessels in their eyes from the pressure. They can have issues with respiratory, with their breathing. So these kiddos can have some significant neurological damage from being shaken. Okay, so that's all I've got on this recording. If you do have any questions, please let me know.